All right, detectives, gather round. Welcome. Today, we're diving into one of the most fascinating mysteries you'll encounter in your practice, a patient presenting with suspected peripheral neuropathy. It can feel like a real head-scratcher, but trust me, with the right framework, we can solve this case every single time.
Here's our game plan for today. We're going to start right at the scene of the crime. Then we'll learn the key questions every good detective asks. After that, we'll map out the evidence, take a trip to the forensics lab, and finally, we'll line up the usual suspects. By the end of this, you'll have a rock-solid method for any neuropathic puzzle that lands on your desk.
Okay, the game is truly afoot. Picture this. Your patient is in front of you describing this cloud of confusing, vague symptoms. They're looking to you, the lead investigator, to find the signal in the noise. And this right here is where the fun begins.
So you get the call. The initial report from the field is numbness, weakness, tingling. Man, that could be anything, right? These clues could point to a dozen different culprits. So the real challenge isn't just figuring out what it is, but knowing where to even start looking.
Every great detective knows, you don't start with the answers, you start with the right questions. We have to learn to observe the patterns, not just see the symptoms. This is the absolute core of good clinical detective work. And here it is. This is your standard issue detectives kit, straight from our field manual, Harrison's. These 7 key questions are your magnifying glass. They help you zoom in and gather those first absolutely crucial clues that will set the entire direction of your investigation.
Okay, question number 1. It's a big one. What is the nature of the disturbance here? Are we dealing with something motor, sensory, autonomic, or, some mix of all three? Pinpointing the system is our first major step.
Let's sort the clues. Is the patient telling you they're weak? Okay, that's a motor clue. Check. Are they talking about numbness, pins and needles, or pain? That's sensory. Check. And we can't forget the autonomic system. Things like getting dizzy when they stand up, or weird sweating patterns. The specific cocktail of systems involved is our first huge lead.
All right, now that we know what's wrong, our next question is when did it happen? What's the timeline? Did this whole thing happen in a flash over a few days, or has it been a slow burn creeping up over months or even years? The timing of the crime can be a dead giveaway.
And look at how powerful this one clue is. An acute case, unfolding over just a few days, your mind should immediately jump to a prime suspect like Guillain-Barré syndrome. But if it's a chronic case, dragging on for months, now we're thinking about totally different culprits, like CIDP, a hereditary cause, or good old diabetes. This single piece of information just dramatically narrows our suspect list.
Okay, we've got our initial clues, but you can't solve a case just by wandering around and hoping you trip over the answer. You need a logical path. Every detective needs a map, and this is yours.
And here's that map. This beautiful diagnostic flowchart is your guide through the wilderness. You start right at the top with your patient's story, and by answering a few simple yes or no questions based on your clues, it points you exactly where you need to go next. It's brilliant.
So let's follow the map. We come to our first big fork in the road. And the question is, are the symptoms widespread, kind of symmetric? If the answer is yes, then we are officially dealing with a polyneuropathy. This is going to be the most common path you take.
And if the answer is yes, well, the map is crystal clear about our next move. Our clinical clues have taken us as far as they can. To really understand what's happening at the scene of the crime, the nerve itself, we have to send the evidence to the lab. In our world, that means electrodiagnostic testing, or EDEX.
All right, welcome to the forensics lab. This is where we get to peek under the hood, so to speak. We're moving beyond the symptoms to analyze the nerve physiology directly. EDX testing is what tells us the type of injury we're dealing with, and that piece of evidence is a total game changer.
Now, what we're looking for in the lab really boils down to this fantastic analogy. Think of a nerve like an insulated electrical wire. The question is the problem with the copper wire itself, the axon? If so, the signal just gets lost, it drops off. Or is the problem with the rubber insulation, the myelin? If that's getting stripped away, the signal doesn't get lost, it just slows way down. It's that simple, axon versus myelin.
And this is how the lab report spells it all out for you. In an axonal problem, the wire cut, you're going to see the signal strength, the amplitude go way down. But in a demyelinating issue, the insulation stripped, the amplitude might be fine, but look at that. The conduction velocity is slow, the distal latency is prolonged, the signal is delayed. It really is that elegant.
All right, detectives, this is the moment we've been working towards. This is the big reveal. We have our clinical pattern from the story and the exam. We have our forensic report, axonal or demyelinating, from the lab. Now, it's time to put it all together and line up the usual suspects.
And this right here is our rogues gallery. It's a list of known offenders, all neatly categorized by their MO, their clinical pattern.
All we have to do is match the evidence we've collected to one of these patterns, and suddenly we have a very short list of prime suspects. Let's try it.
Okay, let's run a scenario. We've got pattern number 1, a classic. Your patient has weakness everywhere, symmetrically, shoulders, hips, hands, and feet. Plus they have sensory loss. That is a very specific signature. So who does this?
A rogues gallery points us to these characters. And now we use our other clues. If the timeline was acute and the lab report screamed demyelinating, then GBS is culprit number 1, case closed. If it was chronic, we're looking hard at CIDP. See how all the pieces just lock into place?
Okay, let's try another one, a really interesting one. Pattern 7, a pure motor mystery. The patient has weakness, but when you check their sensation, it's perfect, totally clean. The sensory nerves are untouched. Now that is a very particular calling card.
And for that specific MO, we've got a whole different lineup. We're thinking about things like a hereditary motor neuropathy, or an immune condition like multifocal motor neuropathy, or maybe even an old school villain like lead toxicity. The pattern dictates the suspects. It's that powerful.
And there you have it. You see, the mystery starts to unravel. It's not so mysterious when you have a method. When you apply this logical, step-by-step process, you move from a place of confusion to a place of confidence and clarity.
So let's just recap your 3-step method. Step 1, gather the clues. Interrogate the symptoms to figure out which systems are involved. Step 2, define the pattern. Use your map, the algorithm, and your forensics lab, the EDX, to define the pathology. And step 3, unmask the culprit. Consult your rogues gallery and match the evidence to the cause.
In the end, this is all about the art of deduction. You gather your data, you follow the logic, you eliminate the impossible. And as a certain famous detective said, whatever remains, no matter how improbable, must be the truth. Now you have the tools. Go solve those cases. The game is afoot.